Dr. Baliga here. Today's podcast is on Menoca or myocardial infarction with non-obstructive coronary artery disease. This podcast is derived from Baliga's textbook of internal medicine, published at www.mastermedfacts.com, and the color atlas and synopsis of interventional cardiology, co-edited by Scott Lilly and myself, and from all the articles cited in this presentation. The burden of Menoca accounts for 5 to 15% of patients with spontaneous myocardial infarctions. Disproportionately, it affects women, 3 times more common among women than men. Greater representation in African American, blacks, Maori, or Pacific race. It's certainly not a benign condition. The 4-year rate of major cardiac adverse events after Menoca is nearly 25%. 17% of decedents with pathological evidence of myocardial infarction at autopsy have no obstructive coronary artery disease. Early in-hospital mortality after Menoca presentation is 1.1%. And Menoca patients who survive to hospital discharge have a 4.7% risk of mortality at the end of 1 year. 5-year mortality is double digits, nearly 11%, and some cases have been identified at autopsy. The Sweetheart Registry reported the risk of mortality, myocardial infarction, and ischemic stroke at 5 years, and it was 13.4%, that's double-digit risk of mortality, 4.3 to 7% of myocardial infarction, and 6.4% of having an ischemic stroke at the end of 5 years. So it's certainly not a benign condition. We need to know more about Menoca so that we can better diagnose and manage and treat this condition. What are the criteria for diagnosis? First, it must meet the universal definition of acute myocardial infarction, including an elevation of cardiac enzymes, troponins, above the 99th percentile of the upper reference limit, and corroborative clinical evidence of infarction according to the 4th universal definition of myocardial infarction. The second criteria is absence of obstructive coronary artery disease and coronary angiography, defined as no coronary artery stenosis greater than or equal to 50%, any potential infarct-related artery on coronary angio. That is, in other words, less than 50% angiographic stenosis in all major epicardial vessels. And the third criteria is there is no specific alternate diagnosis for myocardial infarction presentation, such as sepsis, heart failure, myocarditis, Takotsubo, or pulmonary embolism. The differential diagnosis of Menoca is nicely seen in this Venn diagram, which was published in the British Heart Journal in an article led by Dr. Singh, and Dr. Newby is the senior author. And the differential diagnosis includes excluding conditions which reduce myocardial supply, including coronary artery dissection, coronary artery vasospasm. It also includes conditions which there is a increased demand, such as sepsis, severe hypertension, tachyarrhythmias, and then direct myocardial insults like myocarditis, sepsis, chemotherapy-induced cardiotoxicity, allograft rejection, cardiomyopathies, and myocardial trauma and contusion. And there are some overlapping conditions, including heart failure, pulmonary embolism, Takotsubo, hypoxemia, anemia, and hypotension. So you can see there's a big overlap of differential diagnosis of Menoca. This flowchart, which was published in JACC Imaging recently, nicely sets the approach out for Menoca. So someone with an acute myocardial infarct undergoes a diagnostic coronary angiogram, and if they have obstructive coronary artery disease, Takotsubo or SCAD, then they are treated appropriately. When Menoca is suspected, this flowchart recommends these options, that is OCT, that is optimal coherence tomography or IVUS, a coronary functional assessment like coronary artery spasm, and an early CMR. And the CMR should exclude myocarditis, Takotsubo, and other cardiomyopathies. So once this kind of workup is over, a firm diagnosis of Menoca can be made. Another recent paper in JACC imaging looked at the utility of OCT, optical coherence tomography, and CMR for the diagnosis of patients presenting with Menoca. And according to this paper, the suspected mechanisms for Menoca include plaque erosion, plaque rupture, in situ non-occlusive thrombosis, thrombotic occlusion with thrombolysis or distal embolization, flush occlusion of a branch vessel, SCAD or spontaneous coronary artery dissection, epicardial coronary spasm, and coronary microvascular dysfunction. Despite all this, in 8 to 25% of the cases, there's no underlying cause known for Menoca. And this is important because as we better characterize this condition, and it's really important to characterize this condition because this condition is not benign, as I discussed earlier in this podcast. In November-December 2020, the HARP investigators published their data on Menoca in women in a study led by Harmony Reynolds, MD, from Columbia, and the senior author Judith Hockman. And they found that the mechanisms of Menoca are multifactorial, like I discussed earlier. Nearly 2/3 of the women in this study of 145 patients prospectively enrolled had evidence of a vascular mechanism for their myocardial infarction presentation, with an alternate diagnosis identified in about 1 in 5, that's 20%. When you look at IVUS and optimal coherence tomography in this study, the diagnosis of plaque disruption can be only definitely established with high resolution IVUS or optimal coherence tomography. Intracoronary imaging can also establish the diagnosis of spontaneous coronary artery dissection, which is not apparent angiographically. The AHA scientific statement on Menoca clearly recommends, when available, optimal coherence tomography or IVUS imaging be performed in patients with Menoca and evidence of non-obstructive atherosclerosis. Intravascular imaging with OCT may be preferred to IVUS given the higher imaging resolution. This is a nice figure from the HARP Menoca study, which looked at optimal coherence tomography in women. The study cohort included 145 women. 46% had a culprit lesion, that's 67. 6% had plaque rupture, of which 3% had thrombosis without plaque rupture. Intraplaque cavity was seen in 21%, layered plaque was seen in 13%, spasm was seen in 2%, and SCAD in 1%. That's in one patient in the study. So multivariable analysis showed the culprit was associated with age, abnormal angiography per site, diabetes, but not troponin or angiographic stenosis severity per the core laboratory. Cardiac MRI is useful in the assessment of Menoca. It can confirm the diagnosis of myocardial infarction and exclude symptoms that may mimic Menoca, and this includes myocarditis, Takotsubo, and when MI has occurred, subendocardial or transmural late gadolinium enhancement by MRI may be seen in a coronary distribution, although the absence of a myocardial infarction on cardiac MRI does not exclude Menoca. Cardiac MRI also provides reliable measures of ventricular function, wall motion abnormalities, myocardial thickness. Therefore, cardiac MRI is a key investigation in Menoca because it can exclude myocarditis, Takotsubo, and cardiomyopathies, as well as provide imaging confirmation of an acute myocardial infarction. In the heart Menoca study, infarction was seen in 38 patients, that is about a third of the patients. Regional injury was seen in about 21%. And in 26%, it was normal. Non-ischemic in 21%. And myocarditis occurred in 15%, Takotsubo in 3%, and other cardiomyopathies in 3%. Multivariable analysis, abnormal CMR was associated with higher peak troponin, creatinine, and diastolic blood pressure, but there was no correlation between troponin elevation and angiographic stenosis severity. There was no troponin threshold below which abnormal CMR was unlikely. So the key take away from the Menoca study in women was that both OCT and cardiac MRI are helpful. The OCT, when a culprit lesion is detected on OCT, the cardiac MRI provides evidence of infarction or regional ischemic injury in 69%. So in about 30%, we still don't have supportive evidence for MRI. Ischemic cardiac MRI findings in these patients, 44% had no culprit lesion on optical coherence tomography. And in these cases, one should suspect coronary artery spasm or thromboembolism or a missed culprit lesion. And finally, when they combined both OCT and cardiac MRI, 85% of the cases a cause was identified. With OCT alone, it was 46%, and with MRI alone, it was 74%. So it's really important to have both imaging modalities to better delineate and characterize Menoca. And it's really important we have a better understanding of Menoca, given it's not a benign condition, and we still don't know how to manage and treat these patients. The limitations of the Menoca study was that it was relatively small sample size, very few STEMI cases. The myocardial edema was in a single coronary territory, considered to be an evidence of ischemic injury, but regional myocarditis cannot be excluded. There was no spasm testing, there was no control group, and not all women had 3-vessel OCT and cardiac MRI, and the study was limited to women. These slides were originated from the AHA website of the presentation of Menoca at the last AHA meeting. So the authors of the study concluded multimodality imaging, that is both OCTA and cardiac MRI, is abnormal in 85% of the women with Menoca. They provide useful diagnostic information independently and in combination. Cardiac MRI findings correlated well with OCT culprit lesions, demonstrating that non-obstructive culprit lesions frequently cause Menoca. So non-obstruction doesn't mean it's benign. Coronary artery spasm or thromboembolism likely cause myocardial infarction or regional ischemic injury in cases without a culprit lesion on optical coherence tomography. The study authors went on to conclude that mechanisms of Menoca in women were often similar to the mechanisms of myocardial infarction seen with atherothrombosis, with the possible contribution of coronary vasospasm. These findings have implications for secondary prevention treatment after myocardial infarction in Menoca. It's interesting, in the American College of Cardiology meeting earlier this year, there was a poster where they found that Menoca can present with recurrent ventricular tachycardia, and this patient was a 72-year-old male, had probably had vasospastic episodes which caused ischemia and resulted in monomorphic ventricular tachycardia, and which required ICD shocks. So this highlights that vasospastic angina can present as refractory ventricular tachycardia, and therefore it's really important that we better understand this condition, which has high mortality and high morbidity, including ventricular tachycardia. This slide is from the Stockholm Myocardial Infarction study, and they compared the utility of cardiac MRI 10 years ago and more recently, and they found that an early cardiac MRI and with better technology with cardiac MRI, more and more patients were undiagnosed or were considered normal with Menoca, were probably undetected. And the newer technology in early cardiac MRI, more patients with Takotsubo were detected, more patients with myocarditis were detected, and more patients with myocardial infarction were detected. In the earlier study, cardiac MRI imaging was done a median of 12 days after admission, while in the more recent study, that is SMINC2, it was done within 3 days after admission. So this study emphasizes the importance of early cardiac MRI in patients diagnosed after a diagnostic cath. This case is about a 40-year-old man who had an infralateral STEMI. Diagnostic cath did not show significant blockage, and he underwent optimal coherence tomography, which showed plaque erosion. And in this patient, he received pre-treatment with aspirin, a loading dose of ticagrelor, and IV administration of enoxaparin. Coronary angiography showed mild to moderate lesions in the LAD. The left ventricular angiogram revealed anteroapical wall motion abnormalities. The corresponding OCT images of the proximal LAD showed a thin cap fibroathyroma likely associated. And these arrows heads show the likely this thin cap fibroathyroma was associated with plaque ruptures. CMR, the cardiac MRI, performed 2 days later, showed delayed enhancement, which were located in the anteroseptal wall at the mid-ventricular and apical levels, and also in the anterolateral and inferior walls at the mid-ventricular and apical levels. The LGE pattern was characteristic of coronary artery distribution in the LAD. In this case, the interventional cardiologist in charge decided to stent the culprit lesion, given that there were multiple rupture sites and a significant plaque prolapse. This case was reported in JACC imaging, and one could argue with the approach. In fact, a recent article by Tricia Singh in Heart, or the British Heart Journal, discusses all the management options in patients with Menoca. In plaque disruption, they said one should consider antiplatelet agents, statins, and beta blockers. When there is no atherosclerotic lesion, such as coronary vasospasm, maybe calcium channel blockers, antiplatelet agents if one thinks that microclots are contributing, and secondary prevention to reduce coronary plaque. When there's coronary thromboembolism, they recommend anticoagulant therapy and targeted therapy with patients for hypercoagulable underlying conditions. SCAD one treats, as you all know, depending on depending on the anatomy and the obstruction. Then in conditions with supply-demand mismatch, which we see like sepsis, tachyarrhythmias, anemias, severe hypoperfusion, hypoxias, and pulmonary thromboembolism, the management depends on the underlying pathophysiology. No cause for Menoca has been reported, and so far there is no current guidance on how to approach these patients. In fact, I recall one of my very first few patients with Menoca was a business school professor who was en route to the Middle East, and he developed inferior wall STEMI on a weekend there. He was treated conservatively and came back to the US. When we did an angiogram, it was stone cold normal. Those EKG showed tombstones in the inferior wall leads. And one could argue the best treatment for him would be aspirin, statin, at least at the minimum, and possibly beta blockers. But one could argue that just statins may be adequate once the plaque and the erosions have stabilized. Maybe aspirin for 60 days. There's no data, but given that this condition is not benign and high mortality and occurs with a high burden in women, it is so important to have multi-center trials, prospective trials, to better understand this condition.